Now I'm taking on the role as a case manager, and the past couple of days have been crazy. Hey guys, and welcome back to my channel. My name is Krizia, and if you guys don't know me, I am a new graduate from West Coast University, graduated in January, passed my NCLEX in March of this year, and now I work as an RN admissions hospice nurse. And a lot of things have changed in the past week, and that's what I'm going to be talking about. So now I'm taking on the role as a case manager, and the past couple of days have been crazy. Currently I'm dealing with a patient who is actually actively dying, and so I want to talk about that, the changes and what I've learned in literally like the past 3 days that I've been by myself technically. But let's get into it. A lot of things have happened since the last couple weeks in my role in my new job. So a lot of things have changed because a couple of nurses left, and I've been getting trained, and so my superiors and clinical managers basically believed in me that I can take on the role as a case manager because I was catching on to things quickly, and that I was basically following the case managers, and I was kind of getting how it was to be a case manager. And I was able to do an admission almost by myself. It was like a clinical discharge, and it's like a whole different ball game, like doing everything on your own. So the couple things that I want to talk about today is taking on the role as a case manager and what I've learned about what hospice is really like, especially being on my own, and what I've been facing and some things that like I'm still struggling with and learning as a new graduate. And the second thing that I'm going to be talking about is discussing basically hospice and like the feeling that, or the misconception that hospice is basically killing your patient. And so I'm going to be talking about that and like what I've learned, because when I told my mom, hey mom, what's hospice? She basically said, oh, you're just killing the patient. And I feel like that's what a lot of people think what hospice is that you're killing someone, especially when you're going to be giving morphine. But we're going to talk about that later on. So the first thing is I'm taking on the role as a case manager. I'm taking on a load of 12 patients. Honestly, I don't even know what the plan is. Like, it was just something that I expected to do because I started hearing about a nurse leaving, and I was like, okay, well, who's going to take over that caseload? And then this caseload is closer to my area, and I was like, you know what, I don't mind taking on this caseload. But at the same time, my clinical manager didn't want to throw me in and be like, hey, here's 12 patients, go start being a case manager. No, I'm slowly being put into the position. I'm getting all the help that I need. My clinical manager is actually helping me manage all the medications. Like, they're going to be giving me a list of all the medications and when to order them and all this stuff. So there's a lot of stuff when it comes to case management. So far with what I've learned with case management is you get a caseload of patients. And so with this company that I work for, a full load is about 19, I think. And you'll have these 16 patients that you have to see each week. So each week you have to create your own schedule, and you have to see, okay, this is how many patients I'm going to see this day and this day and this day. So technically you could see 4 patients a day. And then out of those 4 days, if you see 4 patients every day, you basically have like an extra free day to finish charting or finish anything that you need to do, catch up on some stuff. So you would see those 4 patients. Honestly, if you start at like 8:30, you should be done by like 11 o'clock or 12 o'clock latest to seeing your patients, and then you just go home and you finish everything. Some days it's a little different because you could end up with a patient who's actively dying, and you have to add on stuff to your caseload, things that happen, things that the family mentions, things they want to talk about the care, changing cares for your patient. So a lot of things can happen within that. So technically, on a good week, everything should be fine. You should be done with seeing your patients by 12, and then you go home and you chart and you finish your day off at 5 o'clock. But other days can be pretty hectic. And as a case manager, you'd go in, see your patients, assess your patients, and then after you assess your patients, you talk to the caregivers. You see, how are they eating? Have they been decreasing in how much they've been eating? How are their medications? Is there any medications that need to be refilled? Is there anything that they need? And basically that's what it is. You follow these patients weekly. If there's a big change in status and a big change in their care, then something has to be done. So that's basically how case management is. You have the help of a social worker, you have the help of a chaplain, you have the help of all of your coworkers there to help you out. In addition to that, the patients would get baths twice a week from our bath aides. So we have bath aides that would help with that. And so when I was like learning about the role of a case manager, I was like, okay, maybe this is something that I like to do, because you're more in control of your schedule versus within admissions, you're kind of waiting on the sideline. Like, okay, we're waiting for them to sign their consents. And then once they give the consent, then you can go and do the admission. And so it's like a waiting game when it comes to our like admissions. When admitting a patient, you just have to wait until all the information is placed in. And then once the information is placed in, you can go in and admit the patient. So sometimes you may not have an admission, sometimes you may. So it just depends on the day and what's been going on. And the past 3 days I've been by myself. So I have a patient that's currently on SIA, which is basically the patient is on daily visits to see them because they're about to pass. And I've kind of been doing these visits on my own with the help of my preceptor, clinical manager. Like, I'd call like my bosses and superiors and ask them like, what should I do? And it's just, I walk in and then the family's there and I'm just like, how do I deal with the family? I don't know what's going on. But then honestly, you gotta fake it till you make it. You gotta be confident in yourself, and you gotta let these families know that what you're saying is confidently the right answers, but not that you're giving them wrong information. I don't know if that makes sense. So for example, I was doing my assessment on my patient because I was there for the visit, and then the family came in and then they started asking me questions about like morphine, fentanyl, and all this stuff. And then with family and with like care with hospice and case management, it's a lot more teaching than you would do in a hospital, because you're not going to be there to provide care for this patient 24/7. So you have to teach the family about the dying process. You have to teach the caregivers about the dying process, teach them how to administer medications and all this stuff. So there's a lot of education that goes on behind the scenes when it comes to case management or hospice. And so I'm like there by myself, and they're asking me all these questions, and I'm just like, giving them as information that I know that would make them feel comfortable. And so there are certain things that like I get afraid to say in front of patients or like family members, because you're so scared that, or as a new grad, you're scared that like what you're gonna say is wrong. So it's like I feel like I lack that confidence of being confident in myself and my knowledge, and to do what I know, and to do that, and like to not be afraid of it, instead of just like kind of being in the back and just being like, I don't know, yeah, like morphine's gonna help with the pain and stuff. But you have to like let the families know exactly and explain things at a level where they can understand. By myself, and then it just be like in my head, like my head is going crazy, and I'm just like, oh my god, like I'm panicking on the inside, but I'm still trying to have that composure outside, that I'm like know what I'm doing, knowing that I'm confident and all this stuff. So it's like whole different ball game when I'm like by myself, and you start to like develop your nursing process, because when you're a nursing student, you don't get to develop your own nursing process or your critical thinking process, because it's so easy to just walk into a room with your nurse and your nurse is doing that for you, and then you kind of just go, okay, yeah, like we'll follow what they're doing. But like when I walked into that room by myself, then it like hit me like, okay, what am I supposed to do? Like what is happening? And so there's things that happen. For example, like if patients are actively dying, there are certain things that can happen, like respiratory distress. And so it's just things that you have to learn how to manage and like what to do. And a lot of the times working with hospice or home health, you give orders to your doctor, and it's your doctor that says yes or no, versus in the hospital, you're waiting for the doctor's orders to come in. So there's like a lot of autonomy, and there's a lot of independence when it comes to nursing and hospice, because you have to tell the doctor, basically when you're going to ask a doctor for something, you have to ask them, give them information to where all they can say is yes, no, okay. And that's like saying, oh, hey, a patient is having a UTI, can I give them Cipro 500 milligrams twice a day for 10 days? And then they'd be like, okay. Like versus in the hospital, it's like you have to wait for that specific order to come in. But in hospice, a lot of the doctors trust you because they don't see the patients at all. And so what you're telling them is your judgment and the orders that you get. But like you have to make sure that you're getting the okay from the doctors for that. And that's like the 3 days like I've been out by myself. Like today was pretty hectic because a patient was going through respiratory distress. And then, like, in my head, I was like, okay, let me go and, like, do my assessment, get my vital signs, when I should have started my interventions. And it just, literally, ever since I left, I've just been thinking about that visit, thinking about, like, what I can do to be better, thinking about what I could have done differently. And I feel that a lot of nurses go through that, because you go home and you start thinking, like, I should have done this, did I do that, and all this stuff. So it's like, like, the last 3 days by myself have been pretty hectic, and it's so different when you're on your own, but other than that, I wanted to talk about, like, how I've been feeling with hospice, especially when I'm dealing with a patient who's actively dying. And it's so sad. It's not as sad when you're in the room with a patient who's literally, like, dying in front of your eyes, but it's harder when the family's there. And I started to explain to the family, like, this patient is gonna pass soon and you should be ready for it. And then, they start to realize, like, oh, it's soon, it's coming, and then they start crying. And then you get to a point where I'm just, like, in the inside just dying, and all I can do is be there for the family and give them a hug and say, we're here for you, we're gonna help you through this, and to help the patient pass as peaceful as possible. And I feel like that's the hardest part, is seeing the family and dealing with the family. But so far, the families that I've dealt with have been pretty amazing. I haven't had to deal with any families that are, like, very difficult, that make me want to, like, pull my hair out so far, knock on wood. But yeah, it's like my first time having to deal with managing someone's death other than, like, a family member's or something. But it's hard, and it's slowly eating me inside. And I didn't think it was gonna hit me like this, but it's like, I don't know, it's crazy to do bedside nursing for patients who are literally passing. And you learn a lot of things about the human body. You learn about the dying process, and there's a lot of things that you have to, like, learn and realize, and things I didn't even know. Like, I don't learn a lot about patients dying. We learn a lot about how patients are getting better, things that we should watch out for that patients shouldn't have. And then you go into hospice and it's, like, completely different. It's like everything that's supposed to go wrong in the patient is going on with this patient that doesn't normally happen in an acute hospital. And so that's why I feel like it's the misconception of hospice, that when you enter hospice or you take on the role as a hospice nurse, it's like you're killing the patient. In reality, we're not killing the patient. We are helping the patient through their end of life. Sometimes these patients have dementia. They don't even know what's going on. They don't know anything. And then you have patients that have strokes and who have, cancer, that are still fully there and are still fully aware of what's going on. And so you're able to talk to these patients and talk about, things that they like, things that how their lives were. I've talked to patients that are like, yeah, I love In-N-Out. The other day I had another patient who was talking about a man that her boyfriend or something, and it just, like, lit up the patient's eyes. And it's crazy to see, for them to be at this point where they're talking to you and you're interacting with them to a point where it's like they're not even there anymore, or they're, like, dying in front of your eyes. And it's hard. And the thing is, when they get towards the end of life, we kind of start them on morphine. And I know morphine, we all know, is that if you give too much morphine, they'll breathe slower, they might die, you'll slow their heart rate down. When it comes to patients who are actively dying, and when you see someone who's dying, what happens when the patient is dying? In a disease process, in a pathophysiological way. Well, what's happening? The body starts shutting down. The kidneys start shutting down. And so your body is not able to excrete toxins anymore. You have the buildup of your toxins. And then your heart rate isn't as pumping as hard as it was before. Your lungs aren't taking up oxygen as much as it was before. And so the body basically starts deteriorating. You start to lose oxygen throughout the body. And so since like patients' bodies are basically shutting down, they're not getting enough oxygen to their brain, they're not getting enough oxygen to their body. And so certain things that some patients may undergo is respiratory distress. And what I've seen other patients go through towards the end of life is that they start having trouble breathing because they're running out of oxygen, their body's running out of oxygen. And morphine is not, studies have shown for it not to hasten or not to make it faster for them to die. When a patient is running out of oxygen, what does our body do? Our body starts to compensate by increasing our heart rate, by increasing our breathing. And these can become very uncomfortable when you're at the end of life. And so morphine, which can help with that, is going to help improve the circulation of the oxygen in the body because it's going to decrease that oxygen demand. It's going to decrease the oxygen demand that the body needs by slowing down the respiratory rate and slowing down the heart rate so that the patient can feel more comfortable. And at times that can actually prolong their death because their body's not working as hard, because like if your body's working harder and harder, eventually it'll give up. And so with the medication, it'll prevent the body from working too much and kind of sometimes help them last a little bit longer. But you kind of start to learn that what we're doing is helping these patients die with dignity and die in a way that they want to die and not die in the hospital or being, having CPR done, getting tubes placed in their bodies. And that's something at the end of life that you wouldn't want, to happen to you if, as an old person, as an elder person versus someone who's young. Obviously, you want everything to be done when you're someone who's young, but then you enter this other side and world of nursing, which is hospice, and it's not for everyone. And I definitely feel like it's a calling for certain people, and you have to be a certain person to be able to deal with death and to deal with all this stuff that you're going to be dealing with, and it's not easy. And so far I've been having a hard time with it. It's just sad, even though I didn't even know these patients for very long, but it's so sad to see them go and to see how our bodies change throughout life. And it makes me think about my life and just like puts me into a mental health life crisis. But yeah, so I'm taking on the role as a case manager. I don't know if it's going to be my permanent role. I don't know if they're going to end up finding someone else to take on the role later on or what, or if I'm going to be doing like an RN admissions. But that's how my experience has been. I like doing these talks because I feel like it's like a way for me to vent and talk about like what I've been going through. So yeah, it's just, I don't know what the next couple weeks are going to come. It's going to be a whole different learning curve because I'm going to start doing things on my own. I'm going to start developing my own nursing skill, like nursing processes of how I'm going to be able to do things, developing my own way of how to manage patients, manage patients long term. And so that's going to be very interesting because I didn't expect for me to take on the role as case manager this quickly, but I definitely feel like it'll help me become a better nurse, especially if I want to end up taking on the role taking on the role like working in a acute hospital or something, but we'll see. So I hope you guys liked this quick little video for this week. Hopefully next week I can start doing like a follow me kind of thing, but we'll see. And thank you guys so much for watching my last video. I know you guys enjoyed that. I'll also be working on finalizing, like refinancing my loans. So that's a whole nother thing that I'm going to be talking about. But so far, I'm still working on things and stressing out about how I'm going to be paying for everything. So it's just going to be a whole nother video. So that should be coming out, I'd say, next 2 weeks. So stay tuned for that. And thank you guys again for watching. If you guys, again, need any help, you can definitely DM me on my Instagram at crazy__. And don't forget to give this video a thumbs up because it helps my channel a lot, and to subscribe so you guys don't miss any of my videos. Thank you guys for watching.